Our next speaker is Dr. Mustafa Arain, who is an expert in advanced endoscopy, who's going to dazzle us with all the newest, latest, and greatest things. He is currently at UCSF, having been at the University of Minnesota for many years. Dr. Arain.
Thanks. Once again, thank you to the foundation as well as the organizing committee for giving me this opportunity. I really feel privileged, and as I mentioned the other day, and I think this has been reinforced over the last 48 hours, the interactions that we have on a day-to-day basis as one-to-one with patients are in themselves very moving, and I think this meeting for me has especially been just phenomenal. I think the perspective that it puts on the disease burden for everybody involved, and how we can potentially help and sometimes potentially make things worse, just enormous. And I'd just like to say that we will keep continuing to do our best. With that said, I think there is a lot that as gastroenterologists we can do for our patients. And I want to show the slide again. I think based on the previous talk, maybe we should be adding radiation therapy into that sort of multidisciplinary approach, because this truly is a team effort, and without everybody involved and engaged, we can't do what's right for our patients. The difficulty that we face as gastroenterologists often is that we are the first line in terms of a potential biliary obstruction causing jaundice and symptoms. And one of the logistical challenges is how best to triage patients and how best to sort of direct them in terms of management. Oftentimes, one of the issues we run into is that even though something looks like a cancer, a tissue diagnosis is preferable by both our oncology colleagues as well as our surgical colleagues to really even sometimes see the patient in consultation. Having said that, I think we can still be very selective in our approach, and not everybody needs an endoscopy to necessarily make a diagnosis, and it's still incumbent upon us to discuss our patient's presentation before we start delving into invasive procedures. But having said that, I think things to remember, apart from cholangiocarcinoma, of course, the majority of people presenting with malignant disease tend to be with pancreatic cancer. And this distinction, especially with extrahepatic cancer, can be quite difficult to make at times. Secondly, there are benign conditions that can be predisposing, such as primary sclerosing cholangitis, and conditions that can mimic malignancy. Autoimmune disease is a real problem for us as clinicians, because it can present with a mass, it can present with high restrictors, and it can be a very difficult distinguishing sort of effort between cholangio versus autoimmune disease. And this is that same chart I showed earlier about non-invasive versus invasive imaging modalities. And just to sort of recap, always a stepwise progression with the blood tests, tumor markers, non-invasive imaging studies, both to assess the presence of a possible mass, extent, as well as vascular involvement, lymph nodes, and metastases. And then just stop and hold. You know, we get referrals. The way this unfortunately works, and in talking to patients, it's really interesting to hear the perspective from the other side, which I do all the time. But patients show up for an EUS or an ERCP, not really knowing what an EUS or an ERCP is, what the risks are, what the benefits are, what the harm that we can do is. And I think as busy clinicians, we can really jump into things without really stepping back and saying, hold on a second, maybe the best thing for us is not to do this procedure today, and for you to actually see a surgeon and maybe consider going a different route. So regardless, once we have an issue with the biliary system, we're back to that same chart of the three subtypes and the frequency. And the issue is that it may not necessarily be easy, as we've heard in the previous earlier talks, today that to proceed to definitive therapy in the form of surgery. Although in distal cholangiocarcinoma or pancreatic carcinoma, there is quite convincing data that non-endoscopic sort of treatment can be approached right away, and delaying treatment and doing endoscopic procedures may be associated with worse outcomes. That is not always easy, partly because differentiation of pancreatic cancer from cholangio can be tough. There is a role for neoadjuvant therapy, especially in pancreatic cancer, and so a tissue diagnosis may still be required, and benign diseases, as I said, may make an impact and be very hard to differentiate. So that's where the role of EUS plus minus ERCP comes into play. So EUS, or endoscopic ultrasound, basically is an endoscope which has a probe at the end of it which allows intraluminal ultrasound evaluation of the bile duct as well as other organs. It is much higher resolution than any cross-sectional imaging study that we have, so we can see up to 0.1 millimeters resolution as opposed to 1.5 to 2.5 for CT or MRI. It's got a significantly higher sensitivity based on various studies for masses in the bile duct, which can be very subtle to see because they're only maybe 2 to 3 millimeters in size in terms of diameter. And the main issue is that, generally speaking, in the setting of distal cholangiocarcinoma, it is okay to take a biopsy because that is considered part of the area which will be resected, as opposed to the perihilar tumors or intrahepatic tumors. The concern is that by putting a needle across the peritoneal space, we may lead to metastasis of disease, and that's considered a big no-no for obvious reasons, but also for transplantation. It is actually an exclusion criteria. So as gastroenterologists, we just have to be careful and remember not to do that. Here's an example of a patient presenting with biliary obstruction, concern for a distal cholangio versus a mass in the bile duct, and basically an endoscopic ultrasound with a needle going into the lesion, obtaining tissue, having pathology colleagues in the room making slides, confirming a diagnosis, and then moving forward with the endoscopic procedure for biliary drainage, ERCP, placing a metal stent so that the patient can then move on to the next stage of meeting with an oncologist and surgery. Apart from the initial diagnosis, there are other roles for EUS. There may be locations that are not amenable to percutaneous biopsy or other sort of modalities. This was a patient referred for a posterior lesion right next to the IVC, posterior right lobe of the liver, and an EUS from the gastroesophageal junction allowed us to visualize the lesion and obtain biopsies. And then in the role for ongoing treatment for patients who may need newer therapies and they need additional tissue that needs to be tested for various markers, I think there's a growing role and a growing sort of referral pattern for those situations. Our needles have come a long way too. We only used to have what were called fine needle aspiration needles, so that needles would only give us individual cells or blood clot sort of mixed in with cells. The interventional radiology approach of using needles that can give cores of tissue has now been employed for EUS needles as well. And there are a variety of needles. They're pretty much equivalent, but they do allow better cores of tissue to be obtained, which has implications for treatment, of course. So what are the challenges with perihilar tumors? This is something we discussed the other day as well, but the absence of a mass lesion, infiltrative disease, is quite common in these situations. Again, EUS is contraindicated, and that's where the question becomes, should we be doing intraductal biopsies and evaluation, and if so, what is the optimal approach? There's a risk of cholangitis, and once we have entered that space, whether it's percutaneous or endoscopic, we've set patients up for repeated procedures unless they, of course, go for surgery. So in terms of diagnostic options by ERCP, inside the duct, we have multiple. We can take brushings of the cells. We can take directed biopsies. Those cells that we take for brushings can be sent for additional evaluation under the microscope, and I'll get into this a bit. We can look directly with cholangioscopy, and we can do intraductal evaluation with ultrasound or probe-based microscopy within the bile duct. So there are various options at ERCP. Just to go through these, on the leftmost screen, we just are taking a brush. We're just scraping the bile duct wall and making a smear of the tissue, of the cells that we get, and trying to achieve a diagnosis. So the amount of tissue achieved is very minimal, but the cells, individual cells, may allow us to make a diagnosis. We can try and improve on that by taking actual bites of the bile duct tissue, and catheter aspiration for cells has also been performed. But those cells that you can remove with brushings can then be tested for FISH. So basically, tumor cells are supposed to have sort of changes in the number of chromosomes, and the whole idea is that we look for the additional chromosomes in those cells and under the microscope, and that may help us make a diagnosis. Some of the pioneering work has been done at the Mayo Clinic for this. And what they've shown is that when they developed a specific assay for pancreatobiliary tumors in various categories, early versus late cholangiocarcinoma, cholangiocarcinoma versus metastatic disease, or cholangiocarcinoma and carcinoma in the setting of PSC, the FISH analysis performs better than the existing FISH analysis, which was there for primarily for urologic conditions, and as well as for routine cytology. So it increases our ability to pick up cancer, which is also something that came up yesterday in terms of the epidemiology. In the setting of primary sclerosing cholangitis, it's very difficult to differentiate benign strictures from malignant strictures, and FISH may enhance our ability to accurately pick up malignant strictures in the setting of cholangiocarcinoma as well. And cholangioscopy, I showed this video the other day too. It actually allows us to evaluate the bile duct. Subjective evaluation has a sensitivity of about 70%, so our impression clinically by evaluating the lesion isn't quite as accurate, obviously, as being able to obtain biopsies. The limiting factor here is that we're going through a small channel with a small forceps, and obtaining biopsies and the amount of tissue is somewhat tedious, as well as the accuracy. We may get scar tissue, and that may not be adequate. So it's still not the perfect test. The other thing is that in the setting of PSC or other inflammatory conditions, cholangioscopy can mimic tumor, but actually look really ugly, but it's all inflammatory change and not really cancer. So cholangioscopy has its limitations. So how do these, and there are other tests that I didn't really get into because they're not as widely sort of used, but so how do these all line up in terms of sensitivity? If you can increase it, basically a test that is sensitive will pick up disease. Cytology alone, just taking brushings, is only 30-35%. If we take biopsies, that increases it to about 50 to 60. With FISH, we may get up to 70 to 80. In terms of specificity, we can get false positives, especially in PSC. We can obtain biopsies that look very ugly and abnormal, but actually it may not be cancer. But generally speaking, the specificity tends to be high for cytology as well as for FISH. And so essentially it boils down to using whatever tests that you have available at your institution, but pushing the envelope in terms of trying to be aggressive with the testing so that we don't delay a diagnosis and treatment. So we've talked about this before. Intrahepatics likely don't need endoscopic drainage. Perihilar, it's controversial with respect to timing and surgery, and it's more challenging. And distal, not necessary if we're going for surgery, and EUS ERCP has a role. In terms of the perihilar tumors, if it is necessary, there are various considerations. Preoperative, during evaluation for treatment prior to surgery or for palliation. As gastroenterologists who do these procedures, I think the key things that we often want our colleagues to understand is that an understanding of the liver anatomy is so vital. And it is somewhat sometimes surprising when, unfortunately, stents are being placed without a clear understanding of the ductal anatomy. Secondly, the value of placing stents in the right sections of the liver. There is data that I'm going to show you where healthy liver drainage, for obvious reasons, makes more sense than going after areas of the liver that aren't very healthy, are not well vascularized. There's a whole debate in the literature about plastic versus metal stents, and the summary essentially is patency-wise, metals are better, reinterventions-wise, metals are better. Survival benefit is not necessarily determined by the type of stent, but rather, as I'll show you, by what sort of areas of the liver are drained. And then the role for adjunctive therapies with endoscopic approaches. So this is just basics for understanding the anatomy, but essentially, and there are variations of this, but primarily the left side of the liver is divided into 3 segments, 2, 3, and 4. The 2 main ones are 2 and 3, the right anterior into 5 and 8, and the right posterior into 6 and 7. But things to be aware of, and this is where the pre-endoscopic imaging such as MRCP is valuable, is that there can be variations. So the right posterior may drain directly into the left. So in some patients, a single left stent may actually drain 2/3 of the liver, and that's all that may be needed. So why does it matter in terms of where we place our stents? This was a very nice study out of France. They looked at patients who underwent ERCP for biliary drainage for hilar tumors, and what they saw was that the real outcome sort of measure in terms of survival benefit came from the amount of healthy liver drained. So if greater than 50% of the healthy liver was drained, there was a survival advantage as opposed to patients who had less than 50% of the liver drained, irrespective of the type of stent. And this was in the order of 65 versus 119 days, so it's a significant difference. This does sort of somewhat relate to the Bismuth classification, which is often relied on for type of tumor, type of stenting and drainage. So just to recap from the other day, basically 1s and 2s are at the level or below the bifurcation, tend to be easier to place stents for. 3 and 4 means creeping up into the ducts, and there you need multiple stents usually, and that can be more challenging from a procedural standpoint. But back to that French study, in a patient with Bismuth 2 drainage, obstruction rather, placement of a single stent into the right system was enough because the tumors were, there was enough drainage of healthy liver. If there was a 3A with an atrophic left lobe, which is shown here, 2 separate stents into the right anterior and posterior led to greater than 50% drainage. And in a patient with a right posterior atrophic lobe, double stents into the right, single stents into the left anterior was enough to gain drainage of most of the healthy liver. So this basically shows that really it's about appropriate drainage of the liver itself. In terms of the whole issue of 1 or more stents, this is a big debate in the literature, but again, the previous study highlights that it's more important about the right region. Having said that, there aren't really very many good studies on multiple versus single study stents in the setting of hilar cholangiocarcinoma. This recent Korean study tried to address this question with metal stents. This was a randomized controlled trial with 64 patients in quotes, bilateral or multiple stents and 66 in the unilateral arm. And what they found, not so surprisingly, was that there was increased patency with the bilateral arm. However, the patency was defined as the need for reintervention. and there was significant difference. The study did not really take into account healthy versus atrophic liver, and maybe that's, I'll come to that in a second, but secondly, what they also showed was that in the, in quotes, bilateral arm, the rate of decrease of bilirubin was faster. And this obviously has implications for surgery as well as for chemotherapy. But maybe what's really going on is when you break down the patients in bismuth 2s, there was really no difference. So when you look at the 3s and the 4s, these are the ones where the difference was occurring. And also, these are the ones that needed more reintervention, and the primary outcome wasn't being achieved. So this is, again, likely pointing more towards appropriate drainage as opposed to the number of stents. Plastic versus metal, the debate isn't really so much about sort of what's better in terms of survival, as multiple studies have shown that survival is about the same. I think the main issue is patency rate. We looked at our data from the University of Minnesota, and survival did not matter as long as we were doing volume-based directed stenting. But what came out for survival benefit was overall patient status in terms of functional status or Karnofsky score, and overall bilirubin on presentation. In the last few minutes, just about our new adjuvant sort of treatments, or adjuvant treatments rather, with endoscopic approaches. I mentioned this the other day, radiofrequency ablation. So there is a probe, which basically there are two radiofrequency probes 8 millimeters apart. And once we get our tumor identified on ERCP, we advance the probe and ablate the tumor. This study out of China just published this month, a randomized trial looking at a approach of radiofrequency ablation alone versus radiofrequency ablation with stent, stent alone versus radiofrequency with stent placement. And so the design was for only bismuth 1 and 2 patients, so lower tumors. And what they found was there was improved stent patency, improved functional status, but what's really impressive in this relatively small study is the improved survival in patients who received radiofrequency ablation. So this is food for thought for, as we discuss additional therapies for consideration for a more wider spread role of radiofrequency ablation in the setting of ERCP. This can also be done once metal stents have already been placed. And here's a patient from our institution where there was tumor ingrowth into metal stents. Both stents could be accessed and then treated with radiofrequency ablation. The other adjuvant therapy is photodynamic therapy. I don't have a slide on that, but basically there's a photosensitive agent given intravenously, and then at ERCP, a laser probe is advanced to ablate the tumor. The difficulty with that is that this does cause photosensitivity, and so patients do have reactions with that that can at times be quite severe, and patients have to take precautions in terms of avoiding sunlight for up to 2 to 4 weeks. So it's quality of life-wise, it's not very good. And finally, the question of ERCP in Roux-Y anatomy came up the other day because patients, the only other alternative is to have percutaneous drains. And I want to just show you, so basically here we can't get to the bile duct from the duodenum because it's been cut off. So we have to come down the stomach, down the small intestine, come to the sort of the Y anastomosis and figure out which one is the right limb, which is really a matter of luck. And invariably our nursing staff in the room will say, why can't they just mark it at the time of surgery? And we never quite know, but it's obviously there are bigger things to worry about during surgery. But once we get there, essentially we can then evaluate the anastomosis. It just goes to show that sort of the tedious nature of the procedure. You can't even get the pictures on a single sort of slide. But it's a very long scope. Once you get there, you can use accessories to cannulate the duct and do dilation or stenting as necessary. Sorry about that. apologize about these images. So in summary, I think what we've learned throughout this meeting, and I have learned a lot, but would like for people to know that there are a lot of approaches endoscopically for cholangiocarcinoma, for perihilar and distal cholangios. We do have a role to play in terms of diagnosis, but not everybody needs an endoscopic procedure, and as well as for tissue acquisition once the diagnosis has been accomplished. I think there generally is a trend away from percutaneous drainage to endoscopic drainage for quality of life purposes, and I feel that in talking to patients, they feel significantly better with endoscopic stents. And with metal stents, we can reduce that frequency of procedures, but survival is dependent on appropriate stent placement. And I think there will be a role in the future for adjuvant therapies endoscopically, similar to some of the other therapies that have been discussed today. Thank you for your attention.